Thank you. Yes, I am indeed, and I have been in this role for the last 18 months or so. And I have been very privileged to be the lead CNS and project lead for this project here at the Royal Marsden, and just wanted to say thank you for inviting us and listening to us today. Next slide, please. Just whistle stop tour really, because I know Nicola and I could talk for hours about geriatric oncology. But just to give you a bit of overview of our project here at the Royal Marsden, a bit about geriatric screening and our tool, the SOP3, comprehensive geriatric assessments and interventions. And just to give kind of an overall view, I've just got a particular case study for discussion. Next slide, please. Thank you. So the Senior Adult Oncology programme here at the Royal Marsden was commenced in September 2021. Was funded initially by RM partners, so the Cancer Alliance, but this funding unfortunately is due to cease at the end of this month. So because of this, we're currently building a huge business case for optimisation across the trust to get this team substantiated, so we can carry on the good work we've been all doing. CEOP was set up here as a consultancy model, so we accept referrals from the medical oncology teams for patients who are aged 70 and above, and those being considered specifically for systemic anti-cancer treatment. The patients do remain under the care of their medical oncology teams and tumour-specific CNSs. We do currently see most tumour groups here at the Sutton branch, and we've expanded to upper and lower GI and gynecological teams at Chelsea. And I've just commenced reviewing lung and GI patients at the Sir William Rouse unit at Kingston Hospital. So we've gently expanded over the time. We run 2 clinics a week, face-to-face, with telephone appointments in between, and we're very much guided by the patients. We extend referrals out to the community when required and link in with those in the green circles on the right-hand side of the slide, such as safeguarding, palliative care, GPs, hospice teams, and the list goes on really for whichever the patient needs. So as Nicola touched on, our role was to impact under and over treatment for our older cancer population, increase their quality of life, and reduce hospitalisations and toxicities. Next slide, please. So this is our current CEOP team. It consists of our clinical lead, Dr. Battisti, myself, physiotherapist, occupational therapist, dietitian, pharmacist, speech and language therapist, and our PA. And I've just put there, she is the boss, really, which is silent boss. I have purposely given them stars at the top of this slide because they really are. I'm privileged to work alongside each and every one of them, and they work incredibly hard, both in front and behind the scenes, to make such a difference to our patients here. The team are not currently all full-time because we're seconded because it's a project, so they do have other roles in the trust. But despite this and being incredibly busy, they always go above and beyond. And this also includes very much educating, promoting the benefits of geriatric oncology and supporting to develop other similar projects around the country by utilising our own experiences. Next slide, please. Thank you for the claps. So this is our geriatric screening tool here at the Royal Marsden. It's called the CEOP3. It's been adapted from a similar tool used at the Moffitt Cancer Centre in Tampa in Florida. It's devised of 1 to 4 pages of tick boxes, which we encourage the patients to self-complete. The screening also includes a mini cognition assessment, which we call a mini cog. And this takes about 1 to 3 minutes to complete with a member of staff. The mini cog is a very important part of geriatric assessment, as cognition is not routinely assessed in a holistic needs assessment. If abnormal, it doesn't result or dictate a diagnosis of dementia, but it does indicate further investigation from our team. Next slide, please. So from the SOP3 form, we would then triage, and then it would then indicate the patient's needs, which need further review. And we would then offer the patient further assessment by the SOP team in a way of a comprehensive geriatric assessment, which Nicola briefly touched on, and this is our CGA. This is completed by our team, which is already mentioned, consists of myself, pharmacist, speech and language therapist, OT, physio, dietitian, and very importantly, our PA, who I've said she's also the boss, but we couldn't work without her either. She's amazing. The assessment tools are all validated geriatric assessments, and for each geriatric domain on the left, you can see the thorough assessment which then would take place. These assessment outcomes then create the personalised intervention from the team for individual patients. Next slide, please. Thank you. So this is our chemotherapy toxicity prediction tool, the CARG tool, which was developed by the Cancer and Ageing Research Group. And it's very useful and a validated tool to help predict potential toxicities from chemotherapy. And either myself or the pharmacist would complete this tool. And it gives an overall percentage risk of the patient developing grade 3 to 5 adverse events on chemotherapy. This tool in use in clinics may provide and guide confidence in upfront dose reductions for patients, and it's not just using age alone. Although this does ask for age, it also considers renal function, falls, current social activity level, and geriatric domains such as hearing and management by self of medications. And this has been shown to be more accurate than using, as I've said, just performance status alone. Next slide, please. Thank you. So this slide shows the types of personalised MDT interventions, and working in this way can provide greater benefit for patients, such as myself and the pharmacist might create some interventions together, or dietitian and physio collaboration for reducing the risk or preventing sarcopenia. It's all about personalising the patient's interventions under different geriatric domains to provide as much support as possible for the patient. Next slide, please. So this, we had to develop a way of managing capacity within the team, because there is not a lot of us, one each of us. So we developed a current triage traffic light system, which was designed to screen patients based on individual need. So as you can see, we have the red pathway, which if a patient flags or triggers, if you like, on the SOP3, in this case, the SAOP full MDT clinic would be offered, and so the patients could see the whole team in one appointment. Amber would be 1 to 2 flags on the SOP3, and this would generally be directed input by separate members of the MDT, either by phone or matched with an appointment already attending, so no, not necessary for another appointment. And green would be no flags for further support. That isn't indicated at this time, and we do also inform the GP and referring medical team that no additional support was needed at this time, and they're given some what we call top tips advice and a leaflet form to maintain their baseline during their treatment. These appointments are very much guided by what matters to the patient and what they feel comfortable with. Next slide, please. Thank you. So this slide indicates what each member of our MDT assess based on the SOP3 domains, and explains the comprehensive geriatric assessments in more detail, such as function, incontinence, nutrition, psychosocial aspects. We also cover spiritual aspects, and all patients will receive a CARG score if they're going down the route of chemotherapy, comorbidity assessment, and we also complete the Rockwood Frailty Scale, and that's either by myself or the pharmacist. We also request baseline bloods if not done in the medical oncology clinics, including HbA1c, thyroid function, vitamins B12, vitamin D, and also iron. These results are monitored, and any abnormal results are flagged to the medical oncology team and also the primary care team. We found that these results are incredibly valuable prior to embarking on SACT as a baseline, especially when patients embark on immunotherapy, for example, and when steroids are given alongside treatment such as pre-med or anti-sickness prophylaxis. If somebody's got a baseline HbA1c and then whacked with immunotherapy, then if we don't know what their baseline was, then we're not anticipating some of the side effects that could be coming. So next slide, please. Thank you. So just to give you some context, I thought I would put everything together in a case study. And this patient was a delightful 78-year-old lady, and she had stage 4 lung cancer with liver, bone and brain metastases. She'd previously completed radiotherapy to her pelvis and brain and was currently taking osimertinib targeted therapy. The patient was referred to the drug development unit from her local hospital, which was quite far away, for assessment and consideration of a clinical trial upon her disease progressing, which there was some suspicion of. The SOP3, our geriatric screening assessment, was completed by the patient on the same day. Next slide, please. So this was the total of what we obtained from the medical assessment. So medical history was a pulmonary embolism, tinnitus, breast cancer, which was previously excised, and no adjuvant therapy required. She was currently waiting for cataract surgery. The family reported maybe subtle memory loss and previous smoking history. The treatment plan was in consideration with a few options, but a clinical trial was noted, which is why we were asked to see the patient. Interestingly, next slide, please. So this is an example of a full assessment for our patients. So already knowing the previous medical history, to her, she reported on her SOP3 form. She had changes to walking. She was getting tired more quickly. She had changes to her fitness, activity levels. She couldn't exercise as it was affected by her cancer treatment and her cancer therapy. She had urinary incontinence. She couldn't dress, cook, shop without help. She had weight loss, poor appetite, and had lost interest in food. And currently she was taking 10 plus medications. So based on triaging our assessment, she was then suited to the red pathway and was then offered an MDT clinic with the whole team. She was reviewed by myself, dietitian, physio, pharmacist, all in the same clinic, and our OT. And you can see by this, having this assessment led us to be able to give her a much fuller, holistic assessment by identifying areas which were not covered or even discussed in the medical oncology clinic. Next slide, please. Just to give an idea of each individual MDT member, so dietitian review, she reviewed her and she had a mini nutritional score of 17 out of 30, which meant she was malnourished. She had weight loss of 8.6% in 7 months. She had muscle loss. She struggled with constipation, nausea and abdo pain. She did take Movicol, which worked, but when she remembered to take it. Next slide, please. So our dietitian then discussed with the patient and the family the importance of aiming to prevent further muscle loss to support her ongoing treatment, whichever that may be. And she had most likely had the diagnosis of muscle loss and malnourishment due to lack of appetite and lack of interest in her food. Advice and education was provided to optimise her weight loss and optimise nutritional intake to promote weight gain to support her ongoing treatment. Next slide, please. So physiotherapy. The patient, as I said, noted changes to her walking, getting tired more quickly. Her ability to exercise was noticeably impacted by the cancer and her treatment. She'd had bone metastases on her MRI. She had L3 compression fracture, which was osteoporotic, L5 nerve root compression causing a disc bulge. She had received a corticosteroid injection 12 days ago, but with no effect. And just to note, she had no falls or trips within the last 6 months. Next slide, please. Her pain, as you can imagine, was significantly limiting activity, and the day we saw her at 7.8 out of 10. Her hand grip strength showed moderate reduction, so the physio completed a SARC-F, which is our sarcopenia assessment, showed there was an indication of sarcopenia, and clearly her pain was affecting all areas of her body. She did manage some sit-to-stand exercises with the physio, but obviously this was impacted by the pain, so was stopped. The physio applied a TENS machine, which was provided as a non-pharmacological option, and her score actually reduced down to 5 out of 10, so she was able to take that home. The plan was to provide telephone review due to the distance to our hospital and additional support with mobility and exercises as pain allowed, and referral to her local services. Next slide, please. So pharmacy and nursing assessment followed, and this slide just shows the amount of medication the patient was currently on, which triggered for our SOP pharmacist to review under the domain of what we call polypharmacy. Just to note, her observations were all fine. Her laying standing blood pressure was fine. Urinalysis was normal. I did ask her local team to check her baseline medications, as she was due to be having bloods the next day to not having to have another blood test on the same day with us. She had urinary incontinence and she was wearing pads, which the family were buying themselves, but she was noted to have already been referred to the community service from GP. So I chased this, and I also encouraged her to keep a bladder diary as evidence. Her pressure errors were intact, and advice for pelvic floor exercises was given because it's never too late. And just to add, there was no concerning symptoms of cord compression, but we obviously look at the patient as a whole. The patient's abdomen was covered in bruises from administering her own blood thinning injections, and she was clearly struggling. Appropriately, the family were helping, but this was causing a lot of anxiety. Next slide, please. So from the pharmacist's point of view, she pointed out the concurrent use of osimertinib and ondansetron may result in increased risk of QT prolongation. The concurrent use of codeine and serotonergic drugs may result in increased risk of serotonin syndrome. Replacement of dalteparin with an oral replacement due to difficulties with subcut injection, and the need for statin to be reviewed and deprescribed to be considered. Consider risk of anticholinergic burden. Chlorperazine is frequently inappropriately prescribed for dizziness due to postural instability. Next slide, please. So occupational therapy noted from the SOP3, she had incontinence, she needed help to wash, dress, make meals, and needed help to go shopping. Her quality of life score was actually 7 out of 10, so pretty good. Importantly, we also note written as free text on the SOP3 what matters to the patient, and for this lovely lady, it was her family. The mini cog, she actually only recalled 2 words out of 3, and her clock, incorrect placement of clock hands. Next slide, please. So the consultation with the OT unfortunately was cut short because we could clearly see her pain and fatigue were kicking in. So further discussion was taken over the telephone, but it was clear that the family were doing everything they could to support her to be as independent as possible. They all lived together in a bungalow. She had 2 shower cubicles, but she'd been strip washing for years as she didn't feel able to use the shower. She declined OT referral at this point for community assessment of the shower. There was a mattress overlay in situ, and we discussed pressure relieving cushion. Back pain was limiting donning and doffing of her socks. So OT trialled and provided a sock aid when they met at the next appointment. A medication chart was used to make sure medication was taken correctly. No formal cognitive assessment was actually completed in the end, as the family interestingly denied any cognitive concerns in her daily activities, and the patient herself declined any further assessment. So next slide.
Just 1 minute warning, Anne.
Okay, I'm going to be really quick. So just to follow up, her nutritional status improved. She was no longer malnourished. She was starting to help with light housework and cooking. She was using a sock aid and easy reacher, which was provided by our OT. She was referred to the GP again for urinary incontinence, and further assessment support was provided. She was continuing managing her meds with the help of a chart and with support by her son. She actually continued on treatment locally until subsequent disease progression, but she remained much more independent throughout and keen for more treatment. You can actually see how long and thorough these assessments are, and in fact virtually impossible in the medical oncology clinic. And it's also important for us to have conversations around patients' wishes for the future, advanced care planning. What do they deem the most important as priorities of care? And my last slide. Next one, please. So I'd just like to finish off with working in the NHS. We're also passionate about making difference for patients, and I've been very lucky to have the opportunity in this role to really feel like we're making a difference as a whole MDT, to make our patients' journeys just that little bit easier. I've just popped a few quotes from patients on here, and we really do hope that small changes, small steps can lead to big changes. And by spreading the positive impacts of geriatric oncology and subsequent personalised intervention, we can really make a difference to our patients. And next slide is just to thank you for listening.
Thank you so much, Anne. That was really great presentation, very comprehensive overview of your service, and very impressive as well. Do we have any, let me just have a quick look at the chat. Is there anybody with their hands up? Yeah, we've got a couple of hands up. Let's have a look. They've disappeared off my screen. So if you've got your hand up, go ahead. Anybody? No, I've got a quick question then for you both. Obviously, it's great to have such a comprehensive service that you've got at the Marsden, and that we know have got some of the bigger centres have got. If you are working at a smaller centre, and I realise, like you say, the whole package of care that you put in wouldn't be possible in a medical oncology clinic. But if there was just one or two things that you could advise or recommend doing in a medical oncology clinic or in a CNS clinic, what would they be?
God, Nicola, and then I'll say from a nursing point. Yeah,
thank you. So I would say from a medic point of view, 3 things. Prognostication tools. There is something called e-prognosis that you can literally Google and use also in very busy oncology departments to actually understand what is the 10-year mortality of that individual patient. Am I really going to give these patients 6 months of chemo? Maybe yes, because they have a long expectancy, maybe not. Second, chemotherapy toxicity prediction tools, what Annie described. These are models that have been validated in large prospective patient population that can tell me what is this patient individual risk of ending up in a hospital due to side effects. So that actually I can discuss with the patient and say, check whether they would feel it okay or no. Because some people may feel differently about, 10%, 20%, 30%. Third, there are chemotherapy benefit prediction tools. For example, for breast cancer, there is something called the age gap decision tool. You can literally Google it. Was developed by Linda Wild, who is professor of breast surgery in University of Sheffield. Essentially, it's an enhanced version of NHS Predict. Combines the characteristics of the breast cancer, for example, with comorbidities and frailty, instrumental activities of daily living in this specific case, to help me understand what is the benefit of, 12 weeks of weekly paclitaxel for this specific patient, in the context of this prognosis and in the context of this risk of side effects. This is something that, as a medical oncologist, even if I do not have access to the MBT immediately sitting next to me in the clinic, I find incredibly useful to help, achieve what we should call shared decision making. And I don't know if you would like to add your views.
Yeah, I think from my experience over the last 18 months, it's just asking the right questions. I see patients in the medical oncology clinic sometimes if I feel things are being missed in the consultation, and I think it's about urinary incontinence is a massive one. Nearly every patient, and it shouldn't be just based on age, that can impact infections, falls. It's just asking the right questions. And also another one that I am really feel quite strongly about is the polypharmacy. Having a patient that's maybe on 3 different hypertensive drugs that's been on them for 10 years and then is coming in, is falling. Nobody's actually necessarily looking at those drugs. They're looking at other causes, but not actually. So the amount of difference I think you can make just by asking a few key questions is a lot.
Thank you. Did you want to come back in there, Nicola?
Yes, and Annie was saying these are really practical aspects that are so important for patients. Sometimes when the wider oncology profession thinks about geriatric assessment, frailty assessment, they think that these are quite complicated. But actually, for example, the GAP 70 that I discussed, the GAP 70 study, that was something implemented in community oncology practices in the States. We're not talking about the Royal Marsden. We're not talking about fancy cancer centers. We're talking about community oncology, busy oncology practices linked to general hospitals with A&Es and so on. And they were, able to use this very important information to actually make more accurate treatment decisions with the patient.
Thank you so much. That's really answered my question well, and some great top tips as well for others out there. I think we've got time for one more question. And Mary, you've got your hand up.
So I just wanted to kind of ask about the skill set that we have within community teams. I know there's an issue around responsiveness and capacity to support you in your roles for those that don't have the wonderful service that you have. And I just wondered if you're seeing that anywhere, if anybody's making use of that. You're asking the question, you're assessing for it, but then you're referring on to those other teams to follow up and do that work for you.
I think, Mary, that's another excellent point, because I think closer engagement with community services is absolutely critical. These patients have a whole life outside, our oncology clinics. And so what we're trying to do within our services to establish closer links with GPs, memory clinics, community services, charities, for example, transport issues. It's a major problem for the patient that I see in the clinic. Whenever, we do consider them for weekly paclitaxel, that's a weekly intravenous infusion of chemotherapy. So how are they going to cope with that without transport? So absolutely, that's critical. And there was a comment from I think Philippa Hyman in the chat. I think, as I say, there are a few initial proof of concept studies showing that by doing this we can save resources, and these resources can then be used to, for example, pay some protected time for an occupational therapist to actually do these referrals in the community, or as Philippa says, also. I would argue there are no data yet on GP impacts, but my hypothesis is that this is something that will also save resources for busy primary practices or other community services that are going to be seeing probably less this patient because they're being managed more proactively. So we've seen the data on hospitalizations and toxicities. At some point, I suspect we're going to see some more data also from a wider healthcare system perspective.
Lovely, thanks.
Thank you. Just looking at the chat, Philippa, did you have a question, or was that answered your question as well? Or you were on mute?
Yes, I think Nicola just answered that, actually. It's always a difficult, there are some tools that you can use to look at sort of wider healthcare utilisation. I know it's never easy, but it just strikes me that it's so comprehensive and in so many domains that I really imagine there are wider knock-on effects. And I think particularly with business cases now, as people are looking at a whole system and an integrated pathway across primary, community and acute, the knock-on effects in different bits of the system will be something people will be more interested in perhaps than they were in the past, where people just focused on their own individual areas. So yeah, great stuff and great presentation. So thank you.
Thank you, Philippa.
Oh, thank you. And just before we move on to our next speaker, I'm just there's something in the chat here about some JCCO working groups, the guidance that we mentioned, that Nicola mentioned on implementing priority assessment. There's some workshops that are being put on by NHS England. So I think that's on the 10th of May. So if you're looking to implement some of those guidelines in your local centres, there's some workshops being done there. And in the chat, there's an email address for Nicola Beach, who you can email for those workshops. Big thank you again to both our speakers from the Royal Marsden. That was just, really great informative presentations and some great tips as well that we can use in our practice as well. So thank you so much.